So welcome to Having and Caring for Your Baby. My name is Katie. I'm one of the midwives in the maternity unit. I've been a midwife for 18 years. Here at Ashford, we pride ourselves on helping mums and partners bond and care for their babies and have an enjoyable journey through the birthing process. Here at Ashford, we have lots of education and support and facilities for you and your partner to have your baby. Everyone's experiences of pregnancy are different. You may be really enjoying your baby move and feeling the movements, but those movements can also keep you awake at night and cause you to have restless sleep. Movements are very important during pregnancy. Every baby has its own personality, and you as the baby's mother, if you're concerned at any point in time, please don't hesitate to give us a call. They're your best way of knowing that your baby is doing well. So if there is a change in movements that is concerning you at any point in time, have a cold glass of water or a sugary drink, sit down, take note of the amount of movements that you're getting. If they are still concerned to you, please contact your obstetrician or the labour ward staff. So now it's time to talk about labour. So what is labour? Labour is defined as regular strong contractions that are dilating the cervix. For a first labour, the average length of labour is between 12 and 14 hours. So what are some of the early signs of labour? So most of those signs are pretty self-explanatory, but what is a show? A show is a smear of blood. So as you're getting some irregular tightenings or some Braxton Hicks pains, that will soften the cervix and you'll lose your mucus plug. When the mucus plug that has been protecting your baby from any bacteria throughout the pregnancy comes away from the cervix, you'll get a smear of blood. A smear of blood is completely normal. So in early labour, we would recommend you stay at home. Keep the midwives on labour ward updated in your progress. Here are some ideas to help you stay comfortable at home. So when do you need to come to hospital? It's good to call the hospital in advance and talk to the midwife in labour ward, and she will advise you on what you need to do. So if your waters break at home, give us a call. If you're experiencing painful contractions, give us a call. Or if you're experiencing any bleeding that is more than just a smear of blood, give us a call. In some instances, you may need to call an ambulance. In an emergency situation, like labour is progressing very rapidly, or you've experienced a large blood loss, we'll then call an ambulance. So we recommend you pack your bags from about 36 weeks, and here is a list of what to bring in. So when you arrive at hospital, you can be dropped off at the main entrance and your partner can walk you into the labour ward area. The car just needs to be moved and parked securely within the first 15 minutes. So the stages of labour. Labour is defined into 3 stages. The first stage of labour is dilating the cervix. So your cervix is usually a couple of centimetres thick, so it's about 3 centimetres thick. And when labour begins, that cervix needs to thin out to like paper thin and then also start to dilate. You need to get to around 10 centimetres dilated before the end of the first stage of labour. So your contractions start off irregular at times. You might be feeling pains in your tummy, it might be more located in your back. And as labour progresses, the contractions will get more intense and closer together. They might start off 2 in a 10-minute period. By the time you're in strong established labour, you'll be having 4 contractions in about a 10-minute period, and they'll be lasting 60 seconds. So use the gap between contractions to rest and recuperate. Labour is hard work. In this first stage of labour, you're pretty much a passenger to what's going on in your body. Trust your body, it knows what it's doing, but it's working really, really hard. So you need to rest and relax between contractions. The midwife will be with you throughout this stage and will offer you suggestions and ways to help you get through. So as you approach the end of first stage of labour, you hit a period that we call transition. So in transition, quite often you cry, you feel like you can't do it. People ask me for a caesarean, they ask me for an epidural, and they really feel like they can't handle it anymore. You get really squirmy and just nothing is comfortable. Me as a midwife, I like to see that because I know you're getting close to the end of the first stage and you're getting ready to commence the second stage, which is the pushing stage. When you're entering the second stage of labour, we might see another smear of blood, so another show. That is an indication to me as a midwife that you're approaching that second stage of labour. The pain will also shift, so the intensity in your stomach will still be there, but you'll be starting to feel some pressure in your bowel, like you really need to do a big poo. You'll feel that pressure during a contraction. It's time to push when that feeling doesn't go away between contractions. That's when I know you're ready to push. The urge to push can be very overwhelming. So what you want to do is push with contractions, and you want to keep your pushes long and strong. The second stage of labour can last for 1 to 2 hours. As you get towards the end of the second stage of labour and your baby's head is starting to crown on the perineum, your obstetrician will talk you through this last part of birthing your baby so that your baby's head is delivered in a nice controlled fashion. They might talk to you about big pushes, little pushes, or just panting. This is to help minimise any tearing. Once your baby is born, you've reached the end of your second stage of labour and you're now in the third stage of labour. Third stage of labour is delivering the placenta. During your antenatal period, you would have had a discussion with your obstetrician about delivering the placenta. In that discussion, you would have talked about delayed cord clamping. Even if you are having stem cell collection, you still can have delayed cord clamping. So have this discussion with your obstetrician before you come in labour. So once the placenta is delivered, it'll be checked by the midwife for completeness, and then you have the option of taking it home if you want, or it's just disposed of in medical waste. Please let the staff know if you do want to take your placenta home. Prior to coming to hospital, have a conversation with your support person. So talk to your partner about what you definitely do want and what you definitely don't want. They can then be the gatekeepers to your comfort. So talk to them about what music you'd like playing, what food and drink you'd like going, whether you want quiet or whether you want distracting conversation, or whether you want the lights on or it dimmed and nice and quiet so you can rest. The role of the obstetrician is to be your primary caregiver. They may not be with you in the room at all times, but they'll be in constant contact with the midwife, and the midwife will call them if they're required to attend. So pain relief. We always get a lot of questions and a lot of queries about what's available, and there are a lot of options available. In the early stages of labour, you may find simple techniques like massage, water, so baths and showers, to be of benefit for you. You can also get a TENS machine, which is a machine that you put pads on your back and the electric impulses interrupt the nerve sensations. Another common pain relief that is used is nitrous oxide, so the laughing gas. Nitrous oxide won't take away all your pain, but it'll just help the peak of the contraction to be easier to cope with. The good thing about nitrous oxide is that it's in your system really quickly, but it's also out of your system really quickly. When using nitrous oxide, you want to start breathing on the gas mouthpiece as soon as your contraction starts, so that when your contraction hits its peak, the nitrous oxide is working. Then as the contraction starts to ease off, you take the mouthpiece away, you have a couple of deep breaths, and you get it out of your system. Taking the nitrous oxide away and not using it between contractions will help minimise any nausea or vomiting you might experience. Pethidine is a narcotic that is an option for you to use. It is an injection into your muscle. What it will do is cause you to be a bit sleepy and minimise your pain during labour. The problem with pethidine is that it does cross over to the baby. So your baby might also be a little bit sleepy when it's born, depending on the delivery time of the baby. Fentanyl is another narcotic that is used a little bit more frequently these days. It works similar to your pethidine, but the good thing about fentanyl is that it's metabolised a lot quicker, so it's out of your system a lot quicker. But the same with pethidine, it does cross over to the baby, so it can make your baby a little bit sleepy when it's born. So an epidural is a pain relief option that will take away all your pain throughout labour and you can have a sleep. So that's one good thing about it. It is inserted by an anaesthetist, and once the procedure is complete and the drugs are put in it, you get relief within about 10 to 15 minutes. It hits its peak by about the 20-minute mark. During the procedure, the anaesthetist will get you to sit on the edge of the bed, and while you're sitting on the edge of the bed, they get you to slouch into a really bad position that your mum always told you not to do. So we would put a pillow underneath your armpits and get you to slouch over, dropping your shoulders down, and you pop your chin on your chest. That position then opens up the space between the vertebrae so that the needle can be passed next to the vertebrae and into the epidural space. Once the epidural space is found, the needle is then removed and a very thin catheter is left in situ. The catheter is about the size of a fishing line. That then is taped to your back, and every time you want additional pain relief throughout your labour, the midwife will top the epidural up through that catheter. Like with any procedure, there are risks involved. Epidurals are very, very safe. They're very, very common, but there is about a 1 in 100 risk of getting a headache, which we can fix. There is about a 1 in 200,000 of some nerve damage. A spinal anaesthetic is usually used for a caesarean, for an elective caesarean, or a caesarean that is an emergency but an epidural hasn't already been put in. If you've been in labour and you have an epidural but you need to go for an emergency caesarean, the anaesthetist will just use stronger medications through the epidural so that the procedure can commence. If you don't have an epidural in place prior to the caesarean, the anaesthetist will do a spinal anaesthetic. With a spinal anaesthetic, the positioning of the mum is exactly the same. The procedure is pretty much the same. They put some local anaesthetic in, numb the area, then they put a very small needle through, past the vertebrae and into the spinal space. Once they've hit the correct space, they put the medication in, take all needles out and put a band-aid on your back, and the procedure is done. With spinal anaesthetics, they start to work within 1 to 2 minutes. So we get you laying down ready for your caesarean. At times during your labour, you may need extra help to get the baby out. So if the pushing is taking too long, or the baby is becoming stressed and we need to get it out really quick, the obstetrician may assist you to do that. There are 2 devices that they use. One is a ventouse cup, where the little cup is placed on baby's head, and when you push, the obstetrician pulls. The other is forceps. So the forceps are placed around the baby's head, and again, when you push, the obstetrician pulls. This just speeds up delivery. Caesareans can be both elective or an emergency, and there are a variety of reasons why you may need a caesarean. Having a spinal or an epidural anaesthetic for a caesarean enables you to be awake during the procedure and meet your baby as soon as it's born, and it also enables your partner to be with you during the procedure. Make sure that your partner has got your camera, whether it be a phone or a separate camera. have a think about whether you want some music played. The anaesthetists are more than happy to play whatever playlist you bring in. Bring in anything that makes you feel comfortable. Also, I encourage you to bring a beanie for your baby. Theatres are very cold. They are kept cold to minimise bleeding for the person having their operation. But babies come out and they're wet and they get cold very quickly. If your baby gets cold, they'll drop their sugar levels because they burn sugar to keep warm. Enabling your baby to stay warm can be as simple as putting a baby beanie on its head. Then we wrap them up nice and tight, and after the paediatrician has checked over your baby, the baby can come to you for cuddles. Your partner can still cut the cord and you can both have cuddles and get to know your new baby. Once you're in recovery, your midwife will weigh your baby and then pass your baby back to you for skin-to-skin contact and to initiate the first breastfeed. So inductions of labour can happen for a variety of reasons. It may be for maternal health, neonatal health, or for social reasons. It's a multi-step process. The first step is using a cervical ripening device. So that can be either a balloon catheter or a prostaglandins gel. There are two types of prostaglandins gels. One is something that is a gel that's just inserted in behind the cervix with an internal exam. The second one is in a tampon form, so it's more of a slow release. The idea of the cervical ripening device is to give you a few crampy pains overnight, soften the cervix so that an obstetrician can come in the morning and break your bag of waters. Using the prostaglandins gel overnight might be all you need to go into labour. Sometimes your waters will break on their own and you'll go into labour. If you haven't had any of the crampy pains overnight, you may need subsequent doses the next morning. So if the obstetrician can break your waters the next morning, we would then monitor the baby, make sure the baby's happy with what we've been doing. Once you've had the monitor on for half an hour and the baby is nice and happy and healthy, we would get you up and moving to try and get nature to stimulate these contractions to happen. If they don't happen, we then move to the next stage of induction, and that is using an oxytocin drip. So the oxytocin drip is put through a drip in your veins. We started off at a really low level. So we started off at 12 mils an hour and we turn it up every half an hour until you're having regular, strong contractions. The amount that everyone needs is different. Some people never get it turned up past the 12 mils an hour. Some people reach the 196 mils an hour, which is our limit. So this whole process of getting you into labour with an induction is very time consuming. It can take a long time, so be patient. Also tell your relatives to be patient too, because they tend to believe that once you come into hospital to have your baby and be induced, the baby's going to be out in the length of time that a labour would happen. But it's actually the getting you into labour that takes a lot of time. So now that your baby has been safely birthed into the outside world, here are a few things that you can expect in the first couple of hours after the baby's born. So during your hospital stay, use the staff, use the midwives, the physiotherapists, your paediatrician, your obstetrician for information, support and help. We're here to help. So whether it be feeding, wrapping your baby, changing nappies, or just learning how to settle your baby, call for help. During your stay, routine observations will be done. Initially they're done hourly after birth, and then they become less frequent as you progress through the days. On day 3, your baby will be offered some additional routine investigations and tests. These include Sometimes your baby will require some additional support in the special care nursery. Your paediatrician will discuss what is required with you. Some of the reasons your baby may be admitted into the nursery include sometimes babies can be really unsettled. They usually cry for hunger, a wet nappy, or they're just lonely and want to know that you're still around. So there are a few things that you can do, and the staff here at Ashford will help you build up your repertoire of things that you can try. So if your baby has a tummy ache, for example, quite often they'll get relief by being up and forward. So this type of position is really good. Something that dads really like to do, and they can slouch back on the couch and be really comfy. What you want to do is try and bring the baby's knees up to its chest like a little frog, and that will help with the tummy ache. I also like this type of hold, where you can put your heel of your hand on your baby's tummy, so it kind of mimics a hot water bottle or a wheat bag, which we would do if we had a really sore tummy, and you're bringing your knees up to their chest. I like this hold because they're not smelling your breasts, so they're not going to look for food quite as much, and also if they vomit, it goes that way. If your baby's got a little bit of wind after a feed, even though there's no air in your breast, so they're not sucking air, they gulp air when they cry, so they still might have a bit of air in their tummy, so you need to burp them. So after a feed, I wouldn't necessarily sit my baby up and hold it upright and burp it. I like to just, after a breastfeed, slide my baby up over the chest and pat its back and see if you can shift the wind. During the day after feeding, your baby may not go straight back to sleep. They will have some awake time. So to try and initiate some kind of normality between day and night sleeping patterns with your baby, make your daytime feeds fun. So if your baby is awake and happy, hold them out in front and hold them into a stare. So your baby can see about this distance, and hold them out in front and have a chat to them. They want to see your mouth move, and they want to hear your voice. They've been hearing your voice for a number of months, and they want to recognise the person that belongs to that voice. Over the next few weeks, they will hold a stare for longer. This helps with brain development, and they will start mimicking your mouth movements and your sounds, and that's the start of speech development. It's also good to read a book to your baby. So reading cannot start early enough. Child and Youth Health will talk to you about Books for Baby. It's a government scheme where you get a library bag of books and a DVD with the people from Play School on it that show you how to read to a baby. So you can start doing that from the time your baby's born. Another thing you can do is also tummy time with your baby. So lay down on the floor, put your baby on their tummy and give them some tummy time. Make it entertaining for them. If your baby starts to get too tired, these things are no longer going to be enjoyable. So some signs of a tired baby are that they'll get jerky with their movements. They'll start to get really squirmy. They'll no longer hold a stare with you, and they'll get really irritable. And then you know that playtime's over and you wrap your baby up and help them go to sleep. To comply with safe sleep practices, we encourage you to place your baby flat on their back in their cot and have their feet right at the base of the cot so that they can't slip down underneath blankets. Don't put any cot bumpers in your baby's cot because that minimises airflow around your baby. Also, don't have any teddies, pillows, and don't put your baby to sleep at night with a beanie on. Also try and keep your house smoke-free. We also encourage your baby to be in its own cot near your bed in the same room as you for the first 12 months. There There are many community supports out there, and I listed them. An easy, quick reference list is on the back of your baby's blue book. Here at Ashford, we also provide newborn support services for up to 6 weeks postnatally. So before you come into hospital, ensure your car seat is fitted correctly. You can get that checked by either the RAA, the Red Cross, or by the fitting services out the front of baby bunting. So when you're at home with your new baby, it's important to rest when you can, sleep when you can. When you first come home, they're not going to have any concept of when day and night is, and they can't tell the time on a clock. So you need to sleep during the day when you can, otherwise you're going to become too tired. Once you come home, talk to your partner. Open communication will keep your relationship alive. During this time, during sleepless nights and extreme tiredness, send them off for a sleep so that they can be well rested and be helpful for you later in the day so you can then rest. There is no point in both of you in the middle of the night being awake and one sitting on the edge of the bed watching the other one try and settle an unsettled baby. After your baby's born, you're not only going to experience some physical changes, but you're also going to experience hormonal and lifestyle changes. It's not uncommon to have some fears, some tears, but if these feelings become overwhelming and they're occupying every thought you have during the day, please ask for help. You can contact your GP or contact Beyond Blue for support. So in conclusion, enjoy the journey of parenthood. It is an exhausting but exhilarating experience. And at the end of the day, you can't spoil your baby with love.